has been introduced in India also.
Good evening, everyone. So I'm the last man standing in this IC. When you see this title, you would ask yourself, who does this now? But we all know research is objective. You have to have some endpoint, something to measure, and something to tell you that this has an effect or this doesn't have an effect. So that is why these tests are still relevant in the modern day. Many tests are being done all over. What is aqueous humor outflow facility? Simply put, it is the ease with which the aqueous outflow occurs from the eye. We know that the dynamics of the aqueous humor are the ones that maintain the IOP at a steady state, and it is measured in microliter per minute per millimeter of mercury. Different methods are there to measure the outflow facility. All of them have their own advantages and their inherent weakness and may not be reproducible at all times. For us, aqueous humor outflow facility, two main pathways, the trabecular or the conventional and the UV or unconventional pathway. We owe a lot to Dr. Grant in his earlier studies in tonography in the 1950s, and Anders Bill, who brought out UV outflow in the 1960s with his studies on monkeys. To tie them all up together is the modified Goldman equation, as it is put up on the screen, which connects all these parameters. But then why measure? We need to measure. First, you want to find out about the aqueous humor dynamics. What happens? What happens when you use a drug? Does it increase the facility of outflow or not? What happens to the IOP? Does it increase? When it increases, does it affect the outflow facility? And what are the various pathways involved? That is why we need to measure it. Trabecular outflow facility, all are aware what is the outflow facility, but what is important, it is a pressure dependent mechanism. The trabecular meshwork offers a certain resistance to the outflow of aqueous humor, and it's a reciprocal of this resistance that tells us what is the trabecular outflow facility. The techniques, non-invasive ones, are both tonography and fluoro photometry. Invasive techniques, which are more with animal experiments and are more invasive in nature. Tonometry and tonography, they were almost synonymous earlier, but we know that tonography is a method that determines the volume of fluid that leaves the eye in response to a known pressure elevation. So how do we increase the pressure? We can use either a weighted tonometer with either of the two, the electronic shears which Dr. Grant used, or the pneumotonometer used by Langham. Simply put, the principle is the force from the tonometer probe deforms the cornea. It increases the intraocular pressure. This increased intraocular pressure actually pushes through the trabecular meshwork, and the induced pressure change and the volume of aqueous humor for the 2 to 4 minutes during which the test is done is applied to the eye, and you can measure the outflow facility using normograms and standard tables. These are some of the tonometers which are used, electronic Schwartz tonometer, and it indents the cornea with a weighted plunger, and you find the depth of indentation can be directly related to the ocular pressure, and the volumes that correspond to the degree of indentation have been estimated already by Friedenwald and by Langham for pneumotonometer, and they can be directly read out. These are available in almost all the volumes of Becker-Schaffer, as well as you can get it through on the net. In the photograph there, I've just shown both the tonography methods, the indentation with the tonometer, Schwartz tonometer. The Schwartz electronic tonography machine uses a larger probe, which is almost 10 millimeters, while the Langham's tonometer, which is on the left side, uses a smaller probe, which is around 5 millimeters. So Langham and rest have postulated that because of the small size of the probe, it may be that there is less affected by ocular rigidity. Just a small word before it finish tonography. These are the examples of the various tonography units that are used, and you have to lie supine, look upwards, and basically both the eyes are anesthetized. You put the tonography probe on it and record the graph, continuous graph for 2 minutes. There are variations in the procedure where it depends if the patient squeezes his eye, cuffs, Valsalva maneuver, all these can make the test redundant. On the other hand, once you get a good graph, which is a gentle downward slope from the initial IOP reading to the final IOP reading, and these minor small oscillations are due to the ocular pulse, and you draw a slope, draw a line through the graph, have a slope, and nowadays now we have better algorithms with second order polynomial equations that are used. Otherwise, in earlier days, Dr. Grant used to mathematically calculate it with his formulas. There are two assumptions that we make. This is a simplistic equation which shows that the outflow facility due to tonography is due to trabecular meshwork outflow plus the outflow due to pseudo facility and due to the uvascular outflow. In this, an important assumption we make that pseudo facility or the facility of the flow of aqueous humour when the anterior pressure is increased during the placement of the probe is 0. We assume that to be 0, there is no effect. And the other one is ocular rigidity, which is also very important, as we have found that different patients have different ocular rigidities. And the other is uvascular outflow is negligible. So these are the assumptions we make to calculate. And these are the fallacies of tonography. But over time, it has been a time-tested technique. The values that Dr. Grant and others have calculated have still found to be holding true even for these variations in intraocular pressure. Fluoro Photometry assesses the clearance rate of topically applied fluorescein from the cornea and anterior chamber. You load them at before 4 to 6 hours before with topical fluorescein, and then as you can see the graph below, there is a initial loading phase which is constant, and then a fluorescent decay time which you get over time, and you calculate this. So you can calculate the fluorescence by using fluorophotometers like these, and better ones have also come. These are just two different IOP measurements are taken, and you get two different flow rates, and you can use an equation to measure the outflow facility. The advantage of fluorophotometry is directly measures the changes in aqueous outflow. You don't need to worry about pseudo facility or ocular rigidity to confound your measurements. And these are better fluorotrons which have come up now. The mice are being used more often because as they age, their outflow rates are found to be comparable to the human outflow rates. And they are easier and cheaper also. The disadvantages, same. We assume fluorophotometry to be the uvascular outflow to be negligible. And experimental manipulation were to increase the uvascular outflow, then you will confound the results. And of course, it is time consuming. Experimental methods, as we have discussed, are all for research purposes. Basically, it involves sacrificing the animal or you have to use enucleated eyes. Uvascular outflow is now becoming more important because we know prostaglandins are affecting them, and more studies are being done. And the main thing to remember is the route of anatomic uvascular outflow is anatomically ill-defined still, and is relatively independent of the pressure. Again, they have invasive and non-invasive. All of them have their own problems, and there are a lot of variations because of the mathematical formulae which are used. Just a brief thing of the intracameral tracer method, which is used more often, especially in enucleated eyes or in mice eyes, where you have to just measure the fluorescence of each tissue. You have to enucleate the eye and make histological sections, and each tissue, the fluorescence is measured. And then you use radio-labeled isotopes, and then you get an idea of which type of flow is predominant. Future perspectives, one would see with better computer software, better algorithms, we are able to refine our techniques earlier. And functional MRI has been postulated that it will help us to find out optical densities of different tissues and maybe find out real flow imaging, as well as UBM are being developed to find ciliary body volumes to be calculated. Aqueous angioscopy, they found that large intrascleral lumens are there, which actually correlate with better Schlemm's canal function, as well as phase-sensitive OCTs, which show in the ocular pulse real-time movement of the trabecular meshwork. And this real-time movement helps us to know what is the function, how compliant the trabecular meshwork is. With Dr. Sharma had just told us about MIGS. These are some areas where you can actually find out which area you want to put the MIGS. The more functional areas may have a better outcome. And to summarize, clinical applications, you would see with all this, we'd still like to do these tests. They have a specific role. You can find out the outflow facility in both diseased eyes and healthy eyes, and you have an objective measurement. The effect of drugs on outflow, aqueous outflow, which is what actually concerns us a lot now. these and surgical procedures which are being used and which can tell us whether these procedures increase outflow facility or not. And they correlate with structural changes in outflow channels. And for research purposes, we still are using it. And tonography is still being used. I think in St. Thomas Hospital in UK, there are a lot of studies on tonography, post-phacoemulsification, post-SLT, and they found the outflow facility increases. And a lot of work is being done on unconventional aqueous outflow pathways, which may be the future direction for us. Thank you.
Thank you very much.